The Onyx One Global Study was a randomized 2,000 patient study, which was designed to evaluate the efficacy and safety of two modern drug-eluting stents in patients at high bleeding risk. So what we did in the study is we took these 2,000 patients who were identified as having high bleeding risk based on a number of different factors such as age, over 75, using anticoagulants, being at risk of bleeding, having low platelet counts, needing surgery. And these are patients, because they're high bleeding risk, where we would give them only 1 month of dual antiplatelet therapy. And so what we did with these 2,000 patients, we randomized them either to the BioFreedom stent, which is a polymer-free drug-eluting stent, and in Europe, the only stent really approved for this indication of 1 month of dual antiplatelet therapy, versus really a modern, durable polymer drug-eluting stent, which is the Medtronic Onyx stent. So once patients were randomized, they were then treated, they underwent PCI and were treated with either one of the study stents, and at 30 days then, one of the antiplatelet drugs was stopped. And we then, at 1 year, looked at really two endpoints. The primary endpoint was a safety endpoint, really looking at the risk of mortality, having an infarct, and stent thrombosis. And then there was also an efficacy endpoint looking at target vessel failure. So what the study showed was that there was really no difference in the primary endpoint between these two stents, that using a modern, new durable polymer stent like Onyx was as safe as the BioFreedom stent, and there was also no difference in efficacy at 1 year. After reporting the primary endpoint and looking at the outcomes in the primary endpoint, one of the things we noticed was that the event rates were higher than we've seen with some of the other drug-eluting stent trials. We saw for the primary endpoint event rates that were as high as 17%. When we looked a little bit more carefully at the data, we saw that most of these event rates were being explained by myocardial infarction. And so we then did a sub-analysis to really understand why myocardial infarction rates were higher in this study as compared to previous studies. So what we found were a couple of things. Firstly, myocardial infarction in the study was based, the definition was based on the third and fourth universal definition of MI, which really requires a raise in troponin more than 5 times the upper limit, plus evidence of ischemia such as angiographic occlusion of a vessel, ST changes on ECG, or chest pain. What we found in the study is that if you looked at myocardial infarction rates, most of the increase in myocardial infarction rate in this study was explained by periprocedural MI and not by spontaneous MI. So majority of the MIs were actually just periprocedural. And when you looked at the two stents, there was no difference in periprocedural MI between the two stents. We then also did a landmark analysis where we analyzed outcomes up to 30 days and then reanalyzed them from 30 days to 1 year. And we found there was no difference in MI rates up to 30 days, but from 30 days to 1 year, there was a difference, that the Onyx stent was associated with a lower MI rate. Now, what does that mean? We can theorize about it. Could it be related to the durable polymer? Could it be related to the stent design and the thinner struts? We don't really know. I mean, it's all hypothesis generating because the study was not designed for that endpoint. It did, though, highlight a couple of other, another important issue was really how relevant is periprocedural MI rates. So in this study, the Medtronic, who sponsored the study and also provided oversight and monitoring of the study, were really good in ensuring that patients got their post-procedural troponin. So there will be, I think there is some ascertainment bias. What I mean by that is that because the sites and the study was so well followed that most patients got their troponins measured, we picked up more periprocedural MIs. Now, is periprocedural MI a bad thing for patients? That we don't really know. There's conflicting evidence. Probably if patients have very large periprocedural MIs, those could be significant, but probably small troponin rises are not as significant. So when we went into the Onyx One and looked a little bit deeper at the data, what we found was that probably just slightly less than 40% were probably what we would call clinically relevant periprocedural MIs, okay, in the sense that they had very large troponin rises. Most patients had these small troponin rises, more than 5 times upper limit of normal, and most of them, it was associated with probably the operator noticing a small side branch or a small septal branch being occluded. So without evidence of ECG changes or chest pain. Only a minority of patients actually only had ECG changes or chest pain. So it brought into question really, how relevant is the periprocedural MI? We then also looked at and did a multivariate analysis to try and understand what were the predictors of mortality in the study. And what we found was that periprocedural MI was not an independent predictor of mortality. What was an independent predictor of mortality was spontaneous MI. So the patients who had an MI after 30 days, those patients had up to a 3-fold higher risk of dying. I think the study in the end, makes us realize that periprocedural MI, sure, it is an endpoint we use in many studies, but it's not all periprocedural MI is important. It's probably the ones that are more clinically significant that are important. And secondly, that more important than periprocedural MI is spontaneous MI. So what we don't know from the study is if we had continued dual antiplatelet therapy in these patients beyond 1 month, would that have decreased some of the spontaneous MI rates? And I think that's an area for more research. Would in high bleeding risk patients, is 1 month of dual antiplatelet therapy as good as 3 months? And probably that's where the next study should be going.